Okay, you can start the recording. Now we're recording. Good morning, everyone. Thank you for being here. Encompass Health Rehabilitation Hospital of Branford has filed an application for a certificate of need, seeking approval from the Office of Health Strategy to establish a new healthcare facility in Branford, Connecticut. Specifically, it is seeking authorization to establish a 50-bed freestanding inpatient rehabilitation hospital. The proposed capital expenditure is a little less than $70 million. Today is April 16th, 2026. My name is Daniel Chuka. The OHS Acting Commissioner, Amy Porter, has authorized our agency's General Counsel, Tony Casagrande, designate hearing officers for CON matters, and he has designated me to serve as the hearing officer for this matter. Specifically, he has designated me to rule on all motions and recommend findings of fact and conclusions of law upon completion of the hearing. I'm also authorized to take whatever actions necessary to ensure that the hearing is handled efficiently while being respectful of everyone's rights. On that point, I am hoping you all try to be cognizant and respectful of the times that I indicated in my order yesterday, and that you strive to adhere to them as best as possible on your own. I'm hoping that I will not have to force strict adherence, but I will if things become off the rails. It's our goal to finish the hearing today. All that said, this is a hybrid hearing. It is being held in person at 55 Farmington Avenue in Hartford, as well as online utilizing Microsoft Teams. Any person who participates electronically in a meeting shall make a good faith effort to state his or her name and title at the outset of each occasion that such person participates orally during an uninterrupted dialogue or series of questions and answers. To the extent possible, for the people in the room with us, do your best to remind the reporter from time to time who you are. We ask that all members of the public attending remotely mute the device that they are using and access the hearing and silence any additional devices that are around them. This public hearing is being held pursuant to Connecticut General Statute, Section 19A-639A sub E. As such, this matter constitutes a case under the Uniform Administrative Procedure Act and will be conducted in accordance therewith, along with the regulations of Connecticut state agencies beginning at Section 19A-9-24. Although I will be asking the majority of questions, OHF staff is also present to assist me in gathering facts related to this application and may also be asking the applicant witnesses questions. To my side is Boyd Jackson. He's the Director of Legislation and Regulation for OHS. And also to my other side is Annie Fiella. She is CON Team Lead. Also present in person is CON Analyst Olivia Mariano, and attending remotely is Faye Fentis. She's our paralegal. Both of them are assisting with hearing logistics and gathering names for public comment and providing miscellaneous other support. Speaking of public comment, sign up for public comment has started. If you would like to make a statement at today's hearing, please put your name in the Teams question and answer section. The chat has been disabled, or you can sign up in person for anyone appearing in person. We'll be happy to provide you with an opportunity to speak when the time comes. Sign up will continue until 1 p.m., but I believe we have one elected official who's planning to offer comment at 12 p.m. exactly. We'll break for lunch immediately after, then come back at 1 p.m. for the remainder of public comment. You can also submit written comments to concomment@ct.gov for up to 7 days from today. The certificate of need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicant, the interveners, members of the public, and our staff. Our priority is the fairness, integrity, and transparency of this process. Accordingly, decorum must be maintained by all present during these proceedings. The hearing is being transcribed and recorded, and the video will also be made available on the OHS website and its YouTube account. All documents related to this hearing that have been or will be submitted to OHS are available to review through our CON portal, which is accessible on the OHS webpage. In making my proposed decision, I will consider and make written proposed findings in accordance with Section 19A-639 of the Connecticut General Statutes. Lastly, As teams notified you in the course of entering the hearing, I wish to point out that by appearing on camera, you are consenting to being filmed. Wish to revoke your consent, please do so at the time by exiting the meeting, either electronically or in person. So now I'd like to hear from counsel. So counsel for the applicant, can you please identify yourself for the record?
Good morning, Hearing Officer Chuka, Ms. Fiala, Mr. Jackson. For the record, Pat Rocha, and with Pat Sampson, and applicant. Pat and I have been admitted pro hoc vice by your Superior Court. And although we're not full-fledged members of the bar, we have a great affinity for your state. First, we come from neighboring Rhode Island. Second, Pat is a proud graduate of UConn, although I think he's still suffering the recent basketball loss. That's next year. Third, we share colleagues from our respective departments of health. Lita Orafici, your deputy commissioner, Jennifer Olson Armstrong, the senior chief in licensing, came from Rhode Island, and they are terrific. Your gain has been our loss. More importantly, I know Encompass Health. I represented Encompass before RIDO. That's what we call around Department of Health on a certificate of need for the first freestanding 50-bed inpatient rehabilitation hospital, Johnston, Rhode Island. We had many, many objectors. We had hospital systems, we had inpatient rehabilitation units, we had skilled nursing facilities, we had the Hospital Association of Rhode Island, and RICA, the Trade Association for Nursing Facilities, objected. After many, many months of hearing, the Department of Health ruled and it approved the CON application. The objectors appealed. Under Rhode Island law, they're required to exhaust administrative remedies. They filed an appeal with the state agency. Hearing officer was appointed, and after briefing, to my surprise, she reversed the decision. We then appealed to our Superior Court under our Administrative Procedures Act, and I expected Judge Brian Stern affirmed the certificate of need approval, finding that there was an abundance of competent evidence in the record of need portability. Encompass Johnston opened on July of 2024. It's coming upon its 2-year anniversary. It is at capacity. It will be seeking approval to expand. You'll hear Rhode Islanders say that Encompass Johnston is the jewel of the Rhode Island healthcare system. And in fact, Lisa Tomaso, the vice president of the Rhode Island Hospital Association, one of our objectors said, and I'm quoting, Encompass Health's presence in Johnston adds essential services that support patients in regaining functions and independence at a time when the healthcare system requires more, not fewer options for patient recovery. Before we go to our presentations, I do want to make 2 comments. Hearing officer, you took administrative notice of the Danbury proceedings. I don't know if you had a chance to review them, but Marty Chafin, our expert on needs, testified during that proceeding. She will be testifying today. Her methodology, it's data-driven, population-based, using national data, was accepted by OHS and formed the basis for the approval of Danbury. And she'll be using that same methodology today. Danbury opened in September of 2025, and you'll hear that its average daily census has exceeded projections. So the proof is in the pudding. Secondly, I also want to comment that there are no licensed Connecticut providers of inpatient rehabilitation services, whether freestanding or in the hospital setting, objecting. That speaks volumes. Those providers know the experience of Encompass and Danbury, and if there was any adverse impact to the Connecticut healthcare system, they would be here today. They're not. So at the end of this hearing, we are going to ask that you recommend approval of the application on the grounds that the applicant meets the statutory criteria. It will provide choice and access to high quality services to patients needing intensive rehabilitation therapy to regain functioning and get back home to their family and friends as soon as possible so they can continue daily activities. So I'm hoping I have 58 minutes remaining for our presentation.
But believe it or not, we're not there yet. I was expecting you to just introduce yourself. I was going to go around it and do that. So there are some sort of ministerial tasks that we take care of at the outset for most of these hearings. So thank you very much, though. That was very helpful. Attorney Cowherd, can you introduce yourself as well?
Mine will be a little bit shorter. Steve Cowherd of Pullman and Compley on behalf of the Hospital for Special Care.
Can you both of you will have opportunities to make opening statements as well when it's your opportunity.
Isabel B. Clignac from Pullman, probably as well, representing hospitals for special care.
I'm Stephanie Subkoyak from Harris Beach, Merthyr, representing Gaylord Hospital.
Good morning, Lori Letty, also from Harris Beach, Merthyr, representing Gaylord Hospital. And I'm here today with Gaylord's President and CEO, Sonia LaBarbera, with the COO, Peter Gravelding, who's also the Executive Director of the Milne Institute. And online is George Kiriakou, who is the Chief Strategy Officer.
Officers, would you like me to introduce the?
Not yet.
No.
Thank you. So I'm going to be speaking directly to the applicant's attorneys for a little while now. First, I just wanted to acknowledge that yesterday's ruling regarding the New York Times article was probably not what you were hoping for. But I do appreciate your submission of those other records for context. That was really helpful, and it allowed OHS to eliminate a lot of confusion. So I am going to start by going over the exhibits and the items of which I am taking administrative notice, and then I will ask if there are any additional objections that you have not yet lodged. So the CON portal contains the pre-hearing table of record in the case. Exhibits are identified in the table from A through CC. So as I just mentioned, are there any other objections other than the ones that you lodged in writing over the past days?
Objections. If I may, hearing officer, I would ask with respect to your ruling on the New York Times article, if you would reconsider also introducing into the record exhibits 2 and 3, just for purposes of completeness. It shed the bias of the reporter. And we would ask that in addition to exhibit 1, which is the communications between counsel and the reporter, exhibits 2 and 3 also be made part of the record.
I don't think I saw exhibits 2 and 3, so I apologize. It was all supposed to be there. So we'll make sure, we'll do whatever we have to do to make sure that that gets taken.
Okay, I appreciate it. And we'll confirm if they should have been attached, but if not, we'll get the 2.
Okay. So with that, all identified and marked exhibits are entered as full exhibits, including the one that have not yet received, or we have received and hasn't been uploaded to the record. You have any additional exhibits that you wish to enter at this time?
Not this time.
I am going to be taking administrative notice of a few other things. One is the statewide healthcare facilities and services plan and its supplements, the most recent of which was published in 2025. I'm also going to take administrative notice of Table 4 of the healthcare facilities and services inventory, which essentially just lists the IRF providers, the number of beds in the state, as well as the audited financial statements of specialty hospitals in Connecticut. So Gaylord and the Hospital for Special Care are required to make annual filings, and one of those is their audited financial statements. So I don't think I'm going to actually use those as part of my proposed ruling, but I do like to have access to them if I need to. As you mentioned, I am taking administrative notice of the Encompass Danbury docket, which is 20-32392-CON. I'm also going to take administrative notice of the Penn Health at Waterbury docket, which is 21-32490-CON. Both of which have been referred to by the applicant and the limited interveners at various times in the filings. So I think that's appropriate. Do you have any objection to me taking administrative notice of any of this?
Objection.
Thank you. So we will proceed in the order established in the agenda for today's hearing. We may ask questions. We, as an OHS, may ask questions related to your submissions that you feel have already addressed. We will do this for the purpose of ensuring the public has knowledge about your proposal and for the purpose of clarification. We want to reassure you that we have received the continue to do so. As this hearing is being held in hybrid fashion, we ask that all participants attending via Teams enable the use of video cameras when testifying or commenting remotely during proceedings. As I mentioned earlier, all participants in public should mute their devices and should disable cameras when we go off the record. Take a break. To Mr. Jackson's point earlier, there are cameras throughout the room, so even if we stop the recording, people online may still be able to hear you. We can't stop the microphones in the room, so just be aware of that. Public comment taken during the hearing will likely go in the order established by OHS during the registration process. However, we may allow public officials to testify out of order. As I mentioned earlier, registration for public comment has already begun, and it will continue until 1 p.m. Don't think there are any other housekeeping matters. Council, do you have any other housekeeping?
Not at this time, thank you.
Any interveners? Any other housekeeping matters that you want to address at this point?
Only that, at least as limited intervener, contemplate entering into the record earnings of fourth quarter and that earnings call, which I have a copy for the agency as well as the applicant, if permitted. We think it's relevant. I will defer to do that at the appropriate time on cross-examination, but I did want to speak to that.
Okay. So you do plan to ask questions about that document?
And I think it's in keeping with putting in the financials of both the limited and intermediate hearing officer, but defer obviously to the agency on relevance and the mission in the interest. So I said that.
Okay. We can address that when we get there. And I'll provide you with an opportunity to respond. So Attorney Rocha, I am going to allow you to move forward with your case in chief at this point. I'm first going to ask that each witness who you have present with you today identify themselves for the record by name and title, and then I'll swear them all in. Excuse me.
Thank you. Matt?
Matthew Gooch, I'm the regional president of the Northeast region of Encompass Health.
Chapin, I'm the president and founder of Chapin Consulting Group.
Melissa Charbonneau, I'm the Chief Medical Officer for Encompass Health.
Thank you. Can you please all raise your right hand? Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence that you shall give or have already given in this case shall be the truth, the whole truth, and nothing but the truth, so help you God or upon penalty of perjury?
Yeah.
The record reflect that they all affirmed. So Attorney Rocha, you can now proceed. Feel free to make any additional opening comments that you may have. And to the witnesses, please make sure to adopt your written testimony for each of you speak.
Thank you. Our first witness is Matt Gooch, the president of the Northeast region. And Mr. Gooch, first let me ask you, do you adopt your pre-filed testimony?
I do.
I'm going to ask Mr. Gooch to do presentation to you highlighting the substance of his pre-filed testimony. I then have a few questions I'd like to pose, and obviously he's available for questions by staff. Matt?
Well, good morning, Hearing Officer Chuka and OHA staff. My name is Matthew Gooch, as I mentioned before, and thank you for the opportunity to speak to you today about our application to develop a 50-bed freestanding inpatient rehabilitation or IRF hospital in Branford. Today, my presentation will focus high level on who Encompass Health is, go over our proven track record of expertise in the inpatient rehab space, our successful experience opening not only a hospital in Danbury, Connecticut, which was referenced before, but also other new hospitals throughout the Northeast region. And lastly, and most importantly, why we feel this project will improve access to high quality, cost-effective care to residents of Connecticut. Next slide, please.
I was just going to you to pause for one moment. Sure. Your slides aren't actually up there yet, so I apologize.
It works.
To take a minute to,
Is looking it up. Yeah, I don't have.
okay, I have it also.
You just mentioned that it's looking up. Mentioned that it's Mr. Gooch.
Okay. Be the next slide.
That's how I understand it. Who's controlling the slides right now?
Okay, that's.
Okay.
And Matt, would it be easier if you move so you can face the slides? We're having, oh, now have it up.
I have it up, but.
It's whatever I can face the slides, whatever is easiest from a camera perspective. I'm good here though, if that works.
Yeah, okay.
Right. This slide just kind of gives a high level overview of who Encompass Health is. You know, we are the largest owner of operator of inpatient rehabilitation hospitals in the United States. At the conclusion of 2025, we operate over 173 hospitals across 39 states and Puerto Rico. Of note, 39, majority, or a lot of these are joint ventures with leading healthcare systems in the markets in which we operate, which demonstrates the collaborative model and the value leading care that we provide to acute care hospital systems and their ability to get patients to the next level of appropriate care. Annually, we treat over 260,000 patients. We are supported by over 42,000 phenomenal employees. And this scale allows us to consistently deliver specialized, compliant, and efficient rehab services, including in regulated certificate of need states such as Connecticut. Next slide. This slide just kind of highlights our reputation. This validates our reputation is built on measured outcomes, transparency, and trust. I won't go into all of these, but we've been recognized nationally by organizations such as Fortune, Forbes, and Newsweek. These recognitions reflect not marketing, but consistent performance, patient satisfaction, and regulatory compliance. Next slide. From me, and Dr. Lisa Charbonneau will go into some of the additional clinical elements with greater detail, but this slide just highlights our clinical specialization in clinical areas of inpatient rehabilitation. 145 of our hospitals of note hold more than one Joint Commission disease-specific certification. Lead the nation in accreditation for complex conditions such as stroke, hip fracture, brain injury, and amputation. These certifications demonstrate our ability to care for a high acuity level of patient, which is exactly the population that inpatient rehab or IRFs are intended to serve under Medicare and Connecticut standards. We measure quality and success in a lot of different ways, but this slide really kind of drives home the one that is most meaningful to our patients, which is our ability to get patients back home into the life they knew before they had a medical event. This slide deck here, and we are represented in the blue bar there, shows how we benchmark against other inpatient rehabilitation facilities nationally. There's a national database, which is cited below, that accounts for over 80% of IRFs. So you can see historically, we do a great job of getting patients home above other competing inpatient rehab hospitals in the nation. This trend, and you can see the annual improvement in each of these buckets, shows our sustained commitment to providing quality care in an efficient manner. Slide. So what makes inpatient rehab hospitals different? We serve a level of intensity that cannot be replicated in other post-acute providers such as nursing homes or home health agencies. Among the things to highlight here, we do have independent physician oversight. We have 24/7 nursing care throughout all of our hospitals. We have a tremendous multidisciplinary group of therapists and caregivers who help our patients overcome barriers for home discharge. And lastly, we are supported by tremendous clinicians in other aspects, respiratory therapy and such. But this model ensures that patients receive medically necessary inpatient rehabilitation while transitioning them safely back into the communities. Next slide. So in terms of how we stack up from a cost perspective, high quality rehabilitation, as we've demonstrated in our proven track record over the years, is cost effective for the healthcare system. We accomplish that by a few different ways. First, to highlight patients who come to us from acute care hospitals have a much shorter acute care length of stay than in other post-acute settings, such as nursing homes and certainly LTACs, which are a different level of care entirely. With our ability to get patients back home versus sending them to nursing homes or back into acute care hospitals, that gets patients to a lower cost setting, such as going home with outpatient therapy or home health versus going to a nursing home for multiple days or being readmitted back into acute care hospitals. And then lastly, from a hospital readmission standpoint, statistically using Medicare claims data, patients who come to our inpatient rehab hospitals are far less likely to be readmitted back into acute care setting within 30 days of their transition home, which is driven in large part by the intense therapy program and tailored program to the patient's needs that our therapists and clinicians provide on a daily basis. Slide. So I'm going to skip over this video here, but this just kind of shows this is our Danbury Hospital location, which Ms. Rocha mentioned opened in October of last year. There's a video here if you're interested in kind of seeing how these look, but just wanted to reinforce the fact that we are not a new presence in Connecticut. We are very excited, and I'll kind of go into some high-level details here in 2 slides. If you could advance to slide 10, I believe. Turn around, that's okay. So the blue graph here shows where our experience in Danbury, Connecticut has been since we opened in October of last year, compared to the budgetary numbers or the projected volume numbers that we had included in that CON filing. So you can see every month that they have been open, we have exceeded our targeted or our projected census, which demonstrates an unmet need for IRF services in the state of Connecticut. When we put this together, we use the same needs methodology that Ms. Chapin will be speaking about in a little bit. So we think just seeing the experience we've had in Danbury shows that much like Branford, this was a medically underserved area from the IRF perspective, and we're confident that the same needs methodology shows a clear need in Branford, Connecticut for a similar hospital. Next slide. Right. So again, we talked about our experience opening a de novo hospital in Johnson, Rhode Island in July of 2024. At Encompass Health Johnson, you can see here patients who have been given the access to the care that was missing before we entered that market exceeded the national average in both mobility and self-care outcomes, as well as from a patient satisfaction standpoint. They've done a tremendous job. In fact, Encompass Health Johnson was recognized last year at the National Encompass Health meeting for their excellence in patient experience. So we're incredibly proud of the work they have done. And again, we are confident that, if granted this CON for Branford, that patients receiving care there would not only get the great clinical care that they deserve, but also a great overall experience. So again, in summary, my assessment, our assessment of what the Branford IRF will do, it will expand access to high quality inpatient rehabilitation. It'll serve patients with complex medically necessary needs, and it'll support cost-effective care and timely discharges, taking the burden away from our acute care hospital systems that are burdened every day with not having enough beds to care for patients who need them. Encompass Health brings experience, scale, clinical expertise, and a proven track record in Connecticut and the Northeast region of the country. And we respectfully request the Office of Health Strategy support this application and appreciate your consideration. So thank you very much for the opportunity to speak today.
Thank you, Mr. Gooch. And we do invite you to watch the video. It's a beautiful facility, and you'll see how it supports the needs of folks who need intensive rehabilitation therapy to get back home. But in terms of expediency and time, we're going to ask that you do it. I have a few questions, Mr. Gooch. Mr. Gooch, you've reviewed the pre-filed testimony of the interveners, correct?
I have.
And you saw the references to Medicare Advantage, correct?
Yes.
And you're obviously familiar with Medicare Advantage.
Yes, I am.
Right. Can you share with the hearing officer and his colleagues Encompass's success in contracting with and admitting Medicare Advantage patients, including contracts with Medicare Advantage plans in the Northeast. And if you can specifically reference Danbury and Johnston, that would be great.
Sure. So, there's I guess, an insinuation that Medicare Advantage plans are anti-IRF, which they're not. Medicare Advantage plans are anti-unnecessary utilization. So we've actually had an incredibly favorable experience with Medicare Advantage plans. So just to kind of walk you through the basics. So traditional fee-for-service Medicare patients, if they have a rehabilitative need, they qualify for admissions. We don't have to go through a pre-authorization process. Medicare Advantage plans are much more like commercial plans where you have to get authorization for admission into our hospital through our own selectivity. So we get a referral for a Medicare Advantage patient to one of our hospitals. We convert under 30% of those into our hospital, and there's a reason for that. First and foremost, we do not try to get authorization on patients who do not meet inpatient rehab criteria. So if a patient is too high functioning or walking too far in a hospital and doesn't need the kind of therapy we provide, we will not attempt to get authorization for that patient. Conversely, on the other side of the scale, if there's a patient who cannot tolerate therapy because they are too medically complex and should be getting, care in like an LTAC level of care, we will not go for authorization for those patients either. That has created I feel a trust in these managed care plans who not only see the great work that we do that I talked about before, but they know that we're not going to just push every patient through and try to get authorization that is inappropriate. So, from a trend standpoint, and we do recognize that the comment that, traditional Medicare fee-for-service enrollment in Connecticut, is trending on the downward trajectory while Medicare Advantage enrollment is going up. That mirrors what we've seen nationally, and it has had no meaningful impact on our ability or our overall Medicare mix. When I look back to, going back to 2023, our combined Medicare Advantage mix in the Northeast region was 76.5%. At the end of fiscal year 25, it was 78.8%. Through the first full quarter of 2026, that mix has gone up to 79.4%. Where we have seen the greatest gain is actually in our ability to get more Medicare Advantage patients into our hospital. So we feel very, very great, very good about our ability, and that our quality track record, I think, really makes us appeal to those Medicare Advantage plans, and certainly the enrollees who see the value in what we do. Specific to Danbury, so Danbury is just now, as of March of this year, has gotten enrolled in the Medicare Advantage plans. From a process standpoint, we have to get our Medicare number as a new hospital, and then once we get that Medicare number, we can apply to get enrolled in these programs or in these plans. The government shutdown kind of slowed that down a little bit, so we're just now starting to see some Medicare Advantage volume in Danbury. As of this morning, 17% of the patients in the hospital this morning were of Medicare Advantage plans, which kind of mirrors what we've seen from a mix standpoint across our portfolio of hospitals. Specific, Ms. Rocha, to Johnson, Rhode Island, fiscal year 2025, they had 23% of their patients came from a Medicare Advantage plan, and that number is essentially flat the prior year, just under 22% this year. But if you look at the total, I'm sorry, I got those numbers reversed. Last year, their Medicare Advantage mix was 21.7%. This year, it's 23%. So they've actually seen a uptick in Medicare Advantage population. And when we combined, again, traditional Medicare fee-for-service with Medicare Advantage, they're through quarter one of this year, they're 83% Medicare mix versus 80.5% last year. So, both those things I think speak to the credibility and the value that Medicare Advantage plans see in Encompass Health and in the inpatient rehab setting in particular.
Now, you also saw the references to staffing in the pre-file testimony of his interveners, correct?
Yes.
And can you share with the hearing officer and his colleagues Encompass's experience in staffing a new hospital, and specifically how, if you receive approval, how will you staff?
Yeah. So first and foremost, we do not target, any specific group of employees. We don't go after, we're not going to try to recruit directly from any one organization in particular. So our experience is when we go into market, first and foremost, we have our compensation team. They look at the wage scale and the market in which we are going. And we never go into a market trying to price anyone out. So we're not going to come in and have our nursing rates be above what the market is paying or our therapy rates above what the market is paying. We try to set a rate standpoint that makes us competitive, but does not skew and negatively impact others in the market. From a de novo or new hospital opening standpoint, we have a dedicated group of recruiters nationally who recruit, locally, regionally, and across the country to fill these open positions that we need to get our hospital off the ground. So, I think by the lack of opposition from, others in the other inpatient rehab hospitals in the state of Connecticut, and certainly the acute care hospitals, I don't anticipate there being any adverse impact to staffing, which mirrors what we've seen in Danbury, which as of this morning, our Danbury hospital is, we have a bunch of staff still in orientation, but we are fully staffed and ready to increase our census up to 40 by the end of Q2 when these new hire employees get off orientation.
Now I want to turn to Medicaid. And first, let me ask you, with respect to Danbury and Johnston and facilities in the Northeast, does Encompass turn away any patient because of payer source?
We do not.
In fact, is that consistent with Encompass's actions for all of the hospitals throughout the country?
That's correct.
And can you share with the hearing officer and his colleagues, and particularly focused in the Northeast, Encompass's services to Medicaid patients and how that compares percentage-wise to Medicare patients?
Sure. So the only thing we look for when a patient is being admitted to our hospital is, do they have a therapeutic need? Can they benefit from intense physical or intense rehabilitation, which requires, they need physical therapy, speech and or occupational therapy. If a patient meets admission criteria, that is the only thing that we consider. Our Medicaid mix as a company as a region rather is, varies between 6 to 7% of our total patient mix. And it's not because of the payer source, it's just because a vast majority of patients that come to us just by definition of where they are in their life, being of the 65 and older population, that tends to be the most prevalent demographic of patient that we see. But, we are, our main objective is to give patients the care they deserve and the care that they require, independent of their payer source or whatever whatever their insurance plan is.
All right, we're coming up on the 15-minute mark, so I'm just going to focus on two areas at this time. First, in the Hospital for Special Care pre-file testimony, Ms. Rudman talked about the CMS pilot program, transferring episode accountability model known as TEAMS. You're familiar with that, correct?
Yes, I am.
And have you reviewed that program to review the impact on Encompass facilities?
I have.
All right, and what is that impact then?
So, TEAMS, everyone knows, is a 5-year bundled payment program that applies to the Medicare fee-for-service population only. When we looked at it across the company, I'll keep this specific to the Northeast region. In 8 of the 10 states in which we operate, TEAMS is present in those markets. There are 5 categories of, or I guess 5 medical episodes that kind of fall into those TEAMS buckets. Really only 2 of those apply to us in terms of the type of patients that we see. Those would be patients who receive a lower or have a lower joint extremity replacement and surgical and or femur fractures. So and I'll use our Boston market as an example. So TEAMS went live on January 1st. We were very proactive in messaging this with the referral sources, talking about how we can support them in ensuring they're fully compliant with TEAMS. So again, kind of a similar analogy to the Medicare Advantage population, through building trust and only admitting patients who have a true rehabilitative need. We have seen actually no impact through Q1 of any of our markets with who are participating in the TEAMS model. And I'll use our Boston, Massachusetts model as a perfect example. In terms of the number of covered lives potentially impacted, we have actually seen strong quarter-over-quarter. By that I mean Q1 of fiscal year 26 and Q1 of 2025 in those models that have a significant number of teams, potential teams, patients, so it's had no meaningful impact on us. In fact, we've been able to grow our census in those markets. So, we have the bundle payment thing is not new to us. We've lived through the BIPSI, process and others like that. And I expect this will have no meaningful impact, much like those don't, because at the end of the day, it comes back to the quality of patient care, giving patients the care they deserve, and which, patient choice is still prevalent. So, we do a great job, as the slides indicated, of getting patients back home. So no, I didn't anticipate this having a meaningful impact to us, in the region and or as a company.
And finally, based upon your experience, if we receive approval and Branford opens, what impact, if any, will it have on other post-acute care providers, for example, of other freestanding IRFs or in the hospitals or skilled nursing facilities or LTACs?
Yeah, so really no adverse impact that we could forecast, which is, what we've seen in every other market we've gone into. So we look to open between 6 to 8 new hospitals every year in markets such as Branford that are medically unserved. And again, I'll go back to the comment you made, I mentioned before. The fact that there has been no opposition from the acute care hospitals speaks to the value that, they see in us and our ability to get patients to that next level of appropriate care. Similarly, the mention of the other project that was approved in Waterbury last year, I believe, the fact that a competing IRF did not feel the need to contest this project also speaks to them feeling that this is a needed service area and a needed service in the Branford community. So I don't think it's going to have an adverse impact. We do a great job when we enter a new market to build those strategic relationships with providers in the post-acute space. So when our patients leave, even, majority of them, 84% or whatever it is, are discharged home. But for a lot of them, their care journey is still in process, right? They go home and they might need home health. They might need outpatient therapy. For those who go straight home, we will help them, connect with their PCP and schedule those visits. So the transition of care is seamless for them and with their home. And as their healthcare journey continues, we set them up for success. And, we do a great job. Our CEOs and leadership teams do a great job of building those relationships and partnering with organizations who provide the same quality of care that we do.
No further questions.
We typically reserve our questions to the very end, so I want to continue with that halfway in mind. Have witnesses you'd like to present at this time?
So do the interveners do cross-examination at the conclusion?
Yeah, after your whole case in chief.
So we're gonna do a little bit of musical chairs, and Dr. Charbonneau, Chief Medical Officer, will be presenting.
Good morning, Attorney Chuka and members of the OHS. My name is Alyssa Charbonneau, and I am the Chief Medical Officer for Encompass Health Corporation. Thank you for the opportunity to testify in support of this CON filed by Encompass Health Rehab Hospital of Branford.
Let me just pause you for a moment. You have a slide deck as
Yeah.
well, right? Okay.
Getting right through it.
Please.
Hold on one sec. They want to.
Okay. Don't have the eyes in the back of my head today, so I think if approved, this project
Hold
will.
on, Dr. Sharp, just one sec. They want to get the PowerPoint.
Well, they want to get it up.
It's a little awkward.
Can I go?
Yes. Sorry.
If approved, this project will improve patient access to much-needed inpatient rehabilitation services and enhance the quality of inpatient rehabilitative care in the South Central Connecticut and Lower Connecticut River Valley planning regions. And then I will go to my next slide. So I'm going to kind of breeze through some of these first few slides. Really, this is just to show what our hospital looks like, our new hospitals look like, and give you a sense of the patient's rooms and so forth. Next slide. So as you can see, very beautiful, wonderful place to not only work, but also to receive rehabilitation if you are in need of that. Next slide. This actually is an example of one of our bariatric suites. So we typically have facilities available for patients who are of size so that they can get the same rehabilitative services and equipment as all of our other patients. Next slide. In this slide, you can see just a few pictures of our beautiful gym with state-of-the-art technology for patients to use. And also on the right lower hand is our ADL suite, where patients can practice things that they'll need to do at home, like doing laundry and so forth, before they get home, so they're prepared for those kinds of activities. And again, we have all of our hospitals have an outside courtyard. And the reason that this is very helpful for patients is it gives them the ability to mobilize on different kinds of surfaces. So you can see grass, you can see concrete, you can see stairs. So the patients can practice mobilizing on these surfaces before they get out back into the community as well. So this slide just is really to depict kind of the continuum of healthcare services for patients. So there's preventive care, routine care that we all are a part of, hopefully to prevent us from getting sick, ambulatory care when we go to visit a physician. If something bad happens to you, you wind up back in the acute care hospital. And for example, you get sick with some kind of infection, trauma, or a stroke, and then you may not be ready to go straight home from the acute care hospital, but need post-acute care. And post-acute care can be delivered in a variety of settings, including a long-term acute care hospital, inpatient rehabilitation, a skilled nursing facility or a nursing home, or some patients go directly from the acute care hospital home with home health services. So this slide is just really to depict the differences between an inpatient rehabilitation hospital or inpatient rehabilitation facility, IRF is what it's called with Medicare, and a nursing home. So you can see that we don't have any requirement for a minimum stay at an acute care hospital. We require physician visits specifically from a rehabilitation physician 3 times a week. I can tell you with certainty that our patients are seen much more than 3 times a week, usually every day. They need to benefit and need 3 hours of therapy a day, which is quite an intensive rehabilitation program from physical therapists, occupational therapists, and if needed, speech therapists. We have a multidisciplinary team approach to taking care of our patients. And again, a requirement for a rehabilitation doctor, which is a doctor defined by Medicare who has training and experience practicing in rehabilitation. And then we have 24-hour nursing care available on site. Nursing homes do not need to provide that. That's a huge difference in terms of managing patients medically. And one of the reasons why we have a much lower transfer back to the acute care hospital, because we have those nurses on site, and many of our nurses are certified rehabilitation nurses as well. And then we have that discharge to community difference as well. This is Medicare fee-for-service only. Reported data are actual discharge to community for all of our patients last year was over 84%. Next slide. I'm not going to spend a lot of time on this, but basically there were some clinical practice guidelines that came out a few years ago from the American Heart Association, American Stroke Association, which said that patients who've had a stroke who require rehabilitation services are best served in an inpatient rehabilitation hospital. And that was followed up by the Veterans Affairs stroke guidelines and also supported by the JAMA network. Next slide. We have partnered with the American Heart Association, American Stroke Association. In fact, I'm on an advisory board with the American Stroke Association, and the goal of that partnership is to help educate the public on prevention of stroke and prevention of secondary stroke, and we provide a lot of educational resources for the public with them, in partnership with them as well. Slide. This is a slide that really depicts the major differences between an inpatient rehab hospital and a long-term care hospital. So you can see, I think the most glaring difference is the length of stay of our patients. Our patients also met their criteria. 60% of our patients must fall into this, what's called 60% rule, which is a list of 13 different diagnostic categories. But there are 40% of our patients that don't need to fall into those diagnosis groups. And by the way, those diagnoses were decided several decades ago by some physicians who thought what kind of patients would need rehab, and they wrote them down on a napkin, and it's persisted to this day, despite our attempts to try and get that list expanded to other medical diagnoses. So you can see our average length of stay significantly lower than a long-term acute care hospital. Our reimbursement system is completely different. The requirements, as I spoke previously about the 3 hours a day of therapy, is a requirement for us. And the multidisciplinary team, the requirement for a rehabilitation doctor, also a requirement. And the discharge to community rate on a national average, very, very different, 67% from the IRF facilities compared to 17% to long-term care hospitals. And I think that speaks to the very different patient populations that we treat. But so again, this is just a graph showing some of the data for our long-term care hospitals national average. Percent of patients discharged to community is 17%. To the credit of Gaylord and Hospital for Special Care, they're a little bit higher. But again, compared to inpatient rehabilitation hospitals, and specifically Encompass Health, you can see a huge difference in the length of stay in order for us to achieve those goals. So our average length of stay across the company is approximately 12 days. So that indicates that the patients that we're treating are just not as medically complicated or compromised, and we're able to treat them and get them home to the community within a 12, 13-day period, which is just phenomenal for them. Our goal is to get patients that we feel at the time that we evaluate them before they even come into the rehab, our physicians sign off that they're a reasonable candidate, have a reasonable likelihood of improving in a timely fashion in order to achieve these metrics. Slide. And just to talk a little bit about Encompass Health, our whole clinical improvement model is when we do identify a gap in care, we have a very systematic way of evaluating what the need is, using our own internal subject matter experts to evaluate what the need is, and then doing a data analysis, piloting a program that might improve the quality of care before we disseminate it to our hospitals. Next slide. As far as information technology, one of the unique things about Encompass Health is that all of our 173 hospitals are on the same electronic data system. And fortunately, we had the foresight to start using electronic medical records way before it was routine for post-acute care providers. And what that has enabled us to do is since 2010, we have amassed a huge data warehouse with where we're able to use that data to actually improve clinical care because we have it for all of our hospitals feeding into our data. Sure. What? So basically, we have this enterprise scalability. One of the benefits of being involved with a large entity like ours is the availability to use this data to actually improve clinical outcomes. That's truthfully what gets me excited about my job, is that we can initiate quality improvement processes and programs in order to improve our outcomes, improve the patient experience, improve patient care. And our electronic data system is called ACIT, and we have an in-house, very strong IT department that is able to present data to us in a dashboard format, which we call Beacon, which gives clinicians, at the elbow live data in which to evaluate how their programs are doing and identify areas for opportunity for improvement. So as I said, we have a huge data warehouse, and one of the things that has enabled us to do is partner with our electronic health record partner, which was Cerner, which has now been bought by Oracle. We worked with Cerner to design some data analytic predictive algorithms. And three of those are depicted here. One is Rehab. It's actually a trademarked risk assessment of patients who come to us who have an evaluation to see what is their actual risk of potentially needing to be transferred back to the acute care hospital. It's all of these are verified with data analytics and are statistically significant. You can see since we implemented React, had a nice downward trend line in terms of acute care transfers. Our fall risk model, we know that patients that come to rehab are all high risk of falls. The model that was the way we assessed patients previously for fall risk was a nursing assessment that was really designed for acute care hospitals. So if you have an assessment that says 80% of your patients are high fall risk, that isn't really very helpful. We already knew that because that's why they're in rehab. So we wanted to use our own data to evaluate our patients specifically in terms of risk of fall and partner that with our clinicians to add a different ways of handling patients and making sure that we reduce their risk of falls. And you can see that since we implemented our fall risk model, again, very, very proud of reducing our falls, which are reported per 1,000 patient days. A fall with injury is probably like one of the worst outcomes for a patient that's in rehab. We don't want them to fall, hurt themselves, and have to go back to the emergency room or get readmitted to the hospital. The other model that we're also very excited about is our goal is really to get patients home and keep them home. When we look at what factors contribute to patients getting readmitted after discharge from the rehab hospital, we know that it's things like food insecurity, not being able to afford their medications, not having access to their primary care physician, things like that. Also exacerbation of chronic medical conditions, maybe not the reason that they were actually in rehab, but they had all of our patients, most of them being elderly, have many other comorbid medical conditions that can flare up after discharge. So this model enables us to identify patients that we feel are high risk of readmission after discharge from the rehab hospital and see what can we do while we have them for those 12, 13 days to mitigate that risk. So our case managers have resources locally to help patients who need transportation or have food insecurity or other things. Whatever we can do, and it's an interdisciplinary process with our whole team to discuss what we're worried about with this patient after they go home and what can we do to help them stay home. Next slide. When we do rehabilitation, we incorporate technology. Obviously, technology is improving for everyone. The same thing for rehabilitation. So we want to make sure that our patients are getting not only the best technology, but technology that's really useful, that improves their functional skills and will be used by the therapist as well, not become, a coat hanger in the gym. So we have a very robust way of evaluating new technology, again, using our subject matter experts and trialing things in our hospital. You look so uncomfortable. I some Tylenol. This is just an example of some of the things, and it's a whole nother lecture that I could give on the different technology. Next slide. That's it. Okay, I talked really fast.
Thank you. Did you have any direct questions for her?
Yes, if I may. Dr. Charbonneau, in the interest of time, let me ask you two questions. First, what's the dispositive determinative of where a patient should go? For example, to an IRF or an LTAC. Is it the discharge, the diagnosis, or is it the medical condition?
Yeah.
You can use the stroke patient.
Yeah, that's a really good question. So each patient needs to be evaluated individually. So you can have a patient that's a stroke that has mild to moderate impairments functionally, or you can have a patient who has that same diagnosis of a stroke, but it's affected the part of the brain that controls their breathing, for example, the brainstem. So each patient, depending on the severity of their functional impairments and their medical complexity, needs to be evaluated to determine what is the best next level of care for them. In IRF, we are very highly regulated in terms of what criteria do patients need to meet in order to get approved to come to an inpatient rehabilitation hospital. Some of that I discussed previously. They need to be medically stable enough to do that 3 hours of therapy a day. They need to be able to participate. They need to have a good likelihood of improving in a reasonable period of time. They need to require that interdisciplinary approach. So when we get a referral from an acute care hospital, we don't take all of those referrals as Matt explained previously. We have to make sure that those patients meet our specific admission criteria that's set forth by Medicare. Those referrals are then evaluated by, again, a physiatrist like myself or a rehabilitation physician, and they have to attest that that patient meets those criteria and sign off on that admission within 24 hours before they get admitted to our hospital.
And Dr. Chabonneau, Pat just reminded me, I forgot to ask you
Yeah.
if you adopt your pre-file testimony.
I adopt my pre-file testimony.
All right, one last question. You reviewed the pre-file testimony of the interveners, and do you recall the testimony in Gaylord's file testimony regarding their training and research program? Based upon your experience, if we receive approval and Branford opens, what would be the impact, if any, on their teaching and training?
I would actually welcome the opportunity to work with Gaylord to offer clinical rotation sites to their residents and medical students. This is something that we do across the country with other academic programs. We love to train the next generation of rehabilitation providers. We have therapy students, nursing students, medical students, and residents who rotate in our hospitals. And I would think that this would be something that they would welcome, as most programs are looking for additional clinical sites for the rotations. We also have, as I said, a huge data warehouse, which can be used for research purposes and is used for research purposes. And that would be something that we would also love to partner with Gaylord with their academic initiatives to perhaps do some academic studies using our data as well.
I have no further questions. And if we could. May I have one moment?
Sure.
Susan Lyerly just reminded me that
yeah.
Lunsford has dialed in, if this would be a good time.
Okay. Is she able to go up on the screen?
She may be in the waiting room.
We were alerted, excuse me, that the link in the amended hearing notice was flawed and she needs to use the link in the agenda.
Okay. I will send that to her.
Sorry, I was unaware of that.
Okay.
That would be true for public comment people as well.
Yes.
Yes.
To let them know to use the link in the.
So
We did send out a revised media alert to everyone in our database. But yes, let them know, use the link.
All right, so I'm clear. So it's the agenda link.
Yeah.
When we have a break, you know. Do you know what document?
XX.
Is it XX? Yes. That's okay.
So would it make sense to move forward with Ms. Chapin for right now until we sort it out?
Sure, if we could wait 1 minute, if she did just get email and join, otherwise we'll.
She's on.
Okay, great. She's on. Christy, can you put your video on?
Yes, good morning.
Good morning, Ms. Lunsford. I just have a couple questions for you. Thank you for joining us. Can you please raise your right hand and I will swear you in?
Sure.
Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence that you shall give shall be the truth, the whole truth, and nothing but the truth, so help you God or upon penalty?
I do.
Thank you. And so that the limited interveners are aware, she had a limited frame within which she was able to join us. And most of my questions that were going to be posed to her were eliminated, so we didn't see the need to have her attend through the entire hearing. So your attorneys filed Exhibit MM in this docket, which talks about Encompass's June 2019 settlement with the DOJ. Are you familiar with that?
I am.
Okay. So the letter notes that Encompass was not required, nor did it enter into a corporate integrity agreement. Did this experience, in terms of the investigation and going back and forth with DOJ, did that experience result in Encompass voluntarily making any changes in the way that it operates its facilities or bills its claims?
No.
I note that Exhibit MM does not address the October 2019 settlement. Are you familiar with that one?
Can you give me a little more information on the location of that settlement?
That was Nevada. It resolved allegations that Encompass facility in Nevada improperly assigned inaccurate and artificially low admission functional independence measure scores on patient assessment instrument forms. Familiar with that?
I am somewhat familiar with that, but was not prepared to talk about that. But I can try to answer any questions you have.
Are you aware of whether that resulted in a corporate integrity agreement?
To my knowledge, it did not.
And just generally speaking, since 2019, has Encompass taken any steps to ensure compliance with the False Claims Act, other than what it had been doing? So
We
generally
made,
speaking,
yes,
so
well,
generally
we made,
speaking, in response to these DOJ investigations, did they take any additional steps?
we maintain a very strong compliance program. We have enhanced some documentation tools and training for coding and physicians, but we did not admit any issues with either settlement, and there was not a corporate integrity agreement for either settlement.
Thank you. Those are all the questions I had for you. So, thank you for joining. I apologize for sending you the wrong link.
No problem. Thank you all.
Thanks. So you can continue with Ms. Chapin now.
Thank you. And Hearing Officer Chuka, just for the record, when you discussed with us the Department of Justice press release and that settlement, at least I didn't recall a reference to the October 2019 settlement. if you have any further questions, we can late filing if you have any questions.
I think that took care of it. Thank you.
Have one moment. Here, if I may inquire, Marty just said to me, I'm going to skip some of this. We're really trying our best in terms of the time limitation. I really would like you to have the benefit of Ms. Chafin's testimony, which I think will go probably 25 minutes. Is that acceptable?
So that would take us to about 11:15. Sure.
We appreciate it, and we hope will be very informative. So first, Ms. Chafin, do you adopt your pre-file testimony?
My name is Marty Chafin. As I mentioned previously, I am with Chafin Consulting Group, independent of Encompass Health. I work for Encompass on select projects that they bring me in to, in this instance, look at the community needs and develop a CON application, also develop CON applications for other clients across the country as well. I will begin with slide 2 of the presentation. I'll spend just a few minutes here and then I probably will skip some of the slides that are in the pre-file testimony. This information was in the CON application. It is specific to traditional Medicare or Medicare fee-for-service patients. What looks different here is that I have layered in some Medicare Advantage information. So I want to make a couple of points before we get too detailed. Record will speak for itself, but my understanding of what the two interveners, their position versus my position, there's two fundamental differences. One is that based on the data, in my health planning expert opinion, there's a gap in care. Status quo is not okay. At the low utilization rates that I'll walk through, not because everything's okay. The patients that need IRF are getting IRF. It's not what the data shows. It's not my interpretation of the data. My interpretation of the data here is exactly as it was in Danbury. OHS agreed with my interpretation there. And as Matt Gooch testified, Rocha said the proof is in the pudding. Danbury is being a need in the community. The data here is as strong as it was there in terms of that gap in care. So again, the record speaks for itself, but my understanding, the interveners are saying status quo is okay. Don't worry about a gap in care. We're different in Connecticut. They talk about Medicare Advantage as one of those differences. That's why I'll talk about that in a minute. Second fundamental difference in my position and the interveners is that IRF and LTAC are not interchangeable. So all of the analysis that I put forth is patient rehab facility, IRF specific, LTAC, long-term care hospital specific. They're two different entities. They serve two different roles. And at the end of my presentation, I will look at CMS. So I'm not the one making the judgment. You heard from Dr. Charbonneau. She talked medically. I'm going to look at certification from CMS and the data. The slide that you see in front of you shows the Medicare utilization rate by state across the country. Left to right is highest utilization, meaning discharges for 1,000 traditional Medicare or Medicare for service beneficiary to an IRF higher to lower. So for example, Texas is one of the higher utilization states in the nation, also has very similar Medicare Advantage penetration as Connecticut. So all due respect, the interveners seem to be hiding behind, if you will, or leaning on Medicare Advantage is high here, so you can't have IRF services. That's not true across the nation. Gooch talked about it specific to Encompass. Yellow bars here show states in which there are similar or higher Medicare Advantage penetration. As you can see, those states have much higher IRF utilization. So that Medicare Advantage is not, then the IRF would fit here or not succeed here. You look, for example, at, just to give you two, Alabama has a 60% Medicare Advantage penetration rate. It is above the national average in IRF utilization. That is a higher Medicare penetration rate than you have in Connecticut. You look at Florida, 57% Medicare Advantage penetration rate, higher IRF utilization in Florida than you have in Connecticut. What you see to the right is a gap in care. I'll use that phrase, and you've seen it in the CON. That is what I would expect to happen if we're looking at a national average, not even above national average, but the national average. I would expect Connecticut to be closer to that national average. That is why I say there's a gap in care. This is in the CON application. This shows the 21 zip code service area. There were some questions. Okay.
Next slide, please. Oh, she's not controlling it, someone remotely is.
Ms. Chapin, if I could please encourage you to progress the model.
Okay.
Thank you.
Slide 3 shows the 21 zip code service area. As you see, the proposed IRF would be the sole IRF provider within that area. Connecticut went from a county basis to a planning region basis in terms of geography. Talk about that later if needed. South Central Connecticut, Lower Connecticut River Valley are the two planning regions which the primary service area is positioned. Next slide, please, which would be slide 4. This is just another view very quickly to move through that shows the same service area, but gives you perspective of the IRFs around the state. And you see that they are distant from the proposed service area. Heard about the 12 to 13 day length of stay. The close to home concept is not unique to IRF. It is for all healthcare services. Family participation is important here. So the proximity of the IRF to patients is what part of the determination of the service area. Patient migration patterns and other factors as well that we can discuss if needed. Slide 5. This also was in the CON application. A couple of points here. There are IRF providers throughout the state. There are a total of 167 licensed IRF beds. There's some discussion and criticism of why did you use staffed beds versus licensed beds? The CON application really would not matter in terms of gap in care or need for services. And what I mean by that is if there is a quote available bed on paper that is not staffed and it is in Hartford, is not accessible substitute for the proposed beds in the Branford facility. Now look at the bed need calculations. I do include all licensed beds. So this was an indication of the IRFs in the state. What is their utilization of those beds that are staffed? That was simply slide 5 shows. The length of stay that you see here is also used in the bed need calculations, 13.5. Next slide. This is a slide that shows is a basis for the gap in care. You look at what is happening for patients in the general acute care hospital and the post-acute setting. IRF is the outlier. So from a data perspective, I'll spend just a minute on this. And Medicare fee-for-service is the basis of the data that I use for 2 reasons. And I probably should have said it on slide 2, but it's relevant here as well. One is that the Medicare, traditional Medicare or Medicare fee-for-service data is publicly available. Medicare Advantage data is not. It is owned by the commercial insurers that run those programs. So Medicare, traditional Medicare data is publicly available. It is available at the geographic level of a county in Connecticut, a planning region. The second reason that the Medicare data is relevant is that majority of patients in IRFs are Medicare, traditional Medicare, 51%. So it's publicly available. It's an indicator of the need because that's the majority of the patients. What slide 6 shows is that if you compare planning regions in which the zip code patients you expect primarily to be served by Branford, Encompass Branford, the residents in the area utilize general acute care services at a higher rate than the nation. So that tells me, okay, how do you compare nationally in Connecticut when we're talking about general acute care services? You use them a little bit more. It's the 111.5% of discharges per thousand Medicare beneficiaries compared to the U.S. average. Same thing for South Central. Residents are going a little bit more to general acute care. So, and special here in terms of Connecticut is so different from the U.S. that you're not using services. In fact, you're using them a little bit. And when we flip to post-acute care, what you see is similar in terms of home health, higher utilization here in Connecticut in the 2 planning regions versus the national average. Skilled nursing, same thing. Significantly higher utilization here in Connecticut and what I'm going to call South Central Connecticut compared to the national average. So IRF is the outlier. 14%, meaning 2 discharges per thousand, lower River Valley charges per thousand Medicare beneficiaries compared to, for example, sub 13. So when you look at this, your outlier is IRF. And I can look at it as an outlier another way too. That ratio of SNF to IRF is, you know that patients are going to use SNF more. That is happening across the nation. Dr. Chardo talked about the CMS criteria and how strict it is for IRF. That ratio of discharges for skilled nursing to inpatient rehab, the U.S. 54 discharges per thousand, compared to 13 discharges per thousand, or a ratio of 4. You see that hopefully on the screen. You look at what is happening in Connecticut is 5 times that. The difference is significant. It's a ratio of 20. That is because Connecticut has the nation's highest utilization of SNF, one of the lowest utilizations of IRF. They have Medicare Advantage penetration rates about the same as some of the other states that have higher IRF utilization as well. The conclusion from this that I draw is similar to the conclusion we had in Danbury. There is a gap in care. The low utilization is not because patients are getting what they need. It's the exact opposite. They're not getting what they need. Next slide is 7. It is just a graphical representation of the data that was on the prior page. That slide is 8. Point of this slide is to show that the gap in care has been a long-term trend, that the gap in care is increasing. So the difference between what is happening in the service area planning regions, previously the counties of New Haven and Middlesex, they are remaining pretty flat in terms of the IRF utilization per thousand Medicare beneficiaries, while across the nation that number is increasing. So that gap is growing. It's been here and it's growing. Next slide, please. slide 9. The difference, the significant difference in discharges, post-acute care, is not just shown by Medicare data, which is what the previous slides were. It is also shown by Connecticut's own state data. Slide 9 shows that for South Central Planning Region, of the patients that are discharged to post-acute care, home health is blue, skilled nursing is orange, and patient rehab is black in terms of the color of the bars, that it is disproportionately low discharges that go to IRF. Slide 10 shows that the same is true for the lower River Valley region as well. Disproportionate decreasing percentage of patients that are discharged post-acute to compared to home health and SNF. Next slide, 11. So it's been a long-term trend, and I expect it will worsen. Calls, we've already heard from the prior two witnesses, and the data shows that the majority of patients in IRFs are ages 65 plus. The 65 plus population in the service area is increasing 10 times faster than the total population. So it's a significant elderly population and is growing rapidly. Absent the proposed project, that gap in care I would expect to worsen. Next slide, 12. This is the population-based need methodology that was presented in the application. This is the exact same methodology that was accepted and adopted, using the right legal term, by OHS in their approval of the Danbury application. So this is not new. This was exactly what I used in Danbury. Same information here. The most recent data is shown. I'll walk you through it if we go to slide 13. CON application, the bed need based on the methodology shows a need for 49 beds. Was presented in July of 2025. Typically, you will use 5-year planning horizon from a health planning perspective, unless rules state differently. That's a typical 5-year period. So what I've done on slide 13, exact same methodology as was presented in a CON, as was accepted by OHS and approved with Danbury, but rolled forward to 2031 population. It's the only difference. The basis of this methodology is that traditional Medicare population is going to be 51%. That's the national number. Then I've used some local information, such as the 13.5 length of stay. I've accounted for the need for an 80% occupancy factor, which is in Connecticut. We have bed utilization in your state health plan, and that shows a need for 52 beds. Going a little bit quicker just because there was much detail in the CON on these. Slide 14, please. We want to spend a few minutes here. Interveners, it was Gaylord, but again, the record will speak for itself, stated that OHS applied the, call it Encompass methodology to the state, to the 2 counties, and factored in Ham, Waterbury, that there was no need. That's not correct. What slide 14 shows is it takes the exhibit II, which was OHS's application, my need methodology, Connecticut into New Haven County into Middlesex County for 2030. So what you see above the gray was exhibit II with no changes. This was exactly what was presented. What you see in the gray was the correction just for a mathematical error, but it flips, it makes a difference. The OHS exhibit go to, for example, state of Connecticut, down to the line that's 334. That is the number of beds needed, OHS exhibit II. Then an 80% occupancy rate factor was applied. But instead of dividing that 334, 80% to give an adjustment to have sufficient beds to maintain an 80% occupancy, OHS multiplied the 334 by 80%. So they reduced the beds needed by the 80% factor. That results in a 150 bed swing. So let me be very clear for the record. You take 334, you divide it by the 80% occupancy rate, there is a gross bed need of 418. Made no other change to this table. OHS exhibit II showed 268. Again, it was mathematically just an error. It's a swing of 150 beds. That's why I used that number. See 249 beds shown as existing or approved IRF beds. That includes all of the beds that are licensed that we discussed earlier, the 167, and includes Danbury's 40, and it includes Waterbury's 42. There's no licensed IRF bed in the state of Connecticut that was not included in this first column. When you subtract 418, it's 249, there is a net bed need, the state of Connecticut, of 169 IRF beds. That's the math that is consistent with the gap in care, that is consistent with an extremely low IRF utilization rate. Need beds for people to be able to access them. If you look at the next two columns, it's the same thing. It's OHS's information down until you see the gray. What you have in gray is the mathematical correction. For example, New Haven County, there are 81 beds needed, divided by, adjusted for that 80% occupancy, is 101 beds that are needed. 66 beds you see here, contrary to what was said by the interveners, accounts for all 42 Waterbury beds and the 24 beds at New Haven and Milford. It remains just in that county alone, need for 35. Same thing in Middlesex, there is a need for 24. So using the OHS methodology, correcting for that error, there is a need for 59 beds in New Haven and Middlesex County combined. This is for 2030. I did not roll it to 2031. If it were 2031, it would be an even bigger need. Next slide, page 15, please. So we have bed need, I'll call it mine. CON application had a bed need of originally 49, it's now 52. OHS methodology applied to the state and to the two counties shows a need for 59. Now I'm going to turn to Gaylord. Gaylord in their exhibit D had a calculation. They separated Medicare traditional and Medicare Advantage. Again, that goes back to my fundamental difference. It will speak for itself, but it seems to me that they are saying there's such a difference in Medicare Advantage, we got to carve that out. So they did. In Gaylord's calculations, they have national average rate for traditional Medicare that they applied and a national average rate for Medicare Advantage that they applied, meaning the IRF discharge rate for those respective populations per 1,000 beneficiaries. If you apply their discharge rates, what you see is that there is a need for 410, this is in 2030, 410 discharges for Medicare fee-for-service. They call it traditional Medicare. 190 discharges for the Care Advantage. So that's 600. So per their own calculations, there's 600 discharges that they project in service area, 21 zip code service area. Mathematically, they made a mistake there, though. They then increased that by an 18% factor because they have accounted for 82% of the population. So let me step back big picture. They're breaking down Medicare Advantage and traditional Medicare. My analysis did not differentiate those two. When they differentiate the two, that's 82% of the expected patients. So also make the point, that means that almost 1 out of every 3 patient in an IRF, according to Gaylord, is Medicare Advantage. So when they talk about Medicare Advantage not being important or being a problem for IRF, their own data is inconsistent. It doesn't support that position. So I've corrected their math error and I've rolled the population forward. That's in the column to the right. When you do that, under their conservative assumption, the separation of Medicare and Medicare Advantage, there's a need for 40 beds. So the conclusion is the status quo is not acceptable. Data points to a bed need. Otherwise, if you do not have the proposed hospital, flow or freight will continue and patients will choose other services or forego. I'm going to shift now to kind of the second part of my presentation, slide 16, please. When I started out, I said there were 2 fundamental differences. One was the data, interpreting it completely opposite of the interveners. See a gap in care, I see the status quo is not acceptable. The second fundamental difference is that IRF and LTAC are not interchangeable. They are in fact 2 separate unique services. My entire bed need analysis and methodology is based on that premise. You heard Dr. Charbonneau talk about it. You heard Matt talk about it as well. I want to rely on CMS data. So CMS has Medicare Compare websites. You're probably very familiar with that. You can go find a facility near you. What slide 16 shows is that CMS recognizes and identifies, certifies nursing homes, including rehab services, SNF, patient rehab facilities, long-term care hospitals, all separately. So that if you look at one, you will only get that category. Facilities, because they are in fact separate. To the bottom right, you see that I have just given you some national average of discharge to home or community. Charbonneau talked about it. LTAC national average is a 17% discharge to home or community. Very different than IRF, 67% national average, and SNF 51%. Again, they are caring for different patient populations and have different expectations in terms of return to home. And slide 17, please. This is simply drilling down into the SNFs. Again, it's not me saying they're different. It's CMS saying they're different. You look at this slide, you just see that this is for Connecticut. I selected nursing homes. You see the number of nursing homes to the right. I'm going to move quickly. Slide 18. I wanted just to take a minute on Medicare Compare, point out that when you look at skilled nursing facilities, we've heard about it's very different in terms of rehab provided there. This is data from CMS that shows that I picked Mary Wade home here in Connecticut. They average 3 minutes of physical therapy per resident per day. That compares to 180 minutes per resident in an IRF. National average is 4 minutes of therapy per day. Connecticut is an average of 5 minutes. Again, levels of care. Go to slide 19. This is the Care Compare, which is again CMS, long-term care hospitals in Connecticut. There are 2, Gaylord Hospital, Hospital for Special Care. It's not just CMS that identifies those 2 facilities as long-term care hospitals. As you see the note at the bottom, Connecticut Health Strategy, Statewide Healthcare Facilities and Services Plan, March 2025, also distinguishes LTACs and IRFs and states there are only 2 LTACs in Connecticut. Slide 20, please. This is same website, Medicare Compare, inpatient rehab facilities for Connecticut. You see the number. You can see on the screen to the right, there are 7 facilities throughout the state, and that is also consistent with Connecticut's interpretation and statement, its health strategy. Next slide. Slide 21 is, again, CMS data to drive home the point that LTACs, IRFs, SNFs, and home health with all different post-acute care levels. That is simply the point of this. It shows you length of stay per post-acute care provider. It shows you the payment per case. LTAC is the highest. It is for the most intensive patients. See, home health is the lowest, which is what you would expect. It's the least intensive or least acute patients going there. The hours per day, that is again to distinguish IRF from the other 3 acute care services. They don't have the hours per day. They don't have the 60% compliance that Dr. Charbonneau talked about. Given the time, I will just ask to go to 22. Mention that this information is in the CON, and then go to page 23. There are numerous other charts I have in the presentation. They all look at the impact of Encompass coming into a market facility, as has been done in Danbury, is being proposed here in Branford, and showing that there is not an adverse impact on skilled nursing facilities or inpatient rehab providers. Also time. Y'all, unless there are questions.
Thank you, Ms. Chapin. I have no questions.
Okay. It's pretty clear we're going to have to be a little flexible today. This won't cut into any of your time. So my goal is to get through the cross exams by lunch. Which one of you start? So Letty, are you ready to start with that?
I'd like to start with Mr. Gooch, if that's possible. Mr. Gooch, good morning. I think it's still morning. I'm Lori Letty, and I represent Gaylord Hospital. I'd like to ask you some questions about your presentation today, and also about your pre-file and the first completeness response that was filed on behalf of Encompass. My first question is that on page 551 of the record, which is part of your pre-file, you specifically describe Encompass facilities as providing, and I quote, intensive hospital level rehabilitation care for patients recovering from serious illness, injury, and surgery. Does that sound accurate?
Yes, it does.
And you compare it to the level of care that you would be able to get as a patient, either in nursing homes or through home care. Is that correct? When you're talking about intensive, what, in terms of what it means to encompass, what do you mean? Can you define what you mean?
Absolutely. So our patients get 3 hours of therapy a day, 5 days a week. Those therapy plans are tailored towards the patient's individual needs. So, if it's a stroke patient who lives on a second store, has a bedroom in their second floor, we can tailor the care plan to make sure that as they're going through their physical, occupational, and/or speech therapy, that those care plans are specific to barriers for home discharge and getting those patients back to that level of care or getting them back to a home setting.
But in terms of intensive, how do you measure what's intensive? Just by the 3 hours a day of therapy.
Yes, again, the fact that there are no requirements for other levels of care specific to other post-acute providers. We, per CMS guidelines, provide 3 hours of therapy a day, 5 days a week.
In the Encompass first completeness response, draw everybody's attention to, it's page 510 of the record. We were asked to address any analysis that Encompass has done on the impact of opening the facility to provide the LTACs. This would include HFC and Gaylord. Do you recall what the response was?
Not off the top of my head. I can take a
May I
look.
share it with the witness?
Yeah, absolutely.
What question are you referring to, Ms. Wilson?
It's the, actually, it starts at the bottom of 509, goes on to the top of page 5.
Give us one moment.
And I can read it so that everybody's, so that nobody has to flip around. The answer is Encompass does not have information on any impact on long-term acute care hospitals, LTAC, but expects that there would be no adverse impact from the opening of any of its hospitals on LTACs, because LTACs do not provide the same level of intensive inpatient rehabilitation services as an IRF. That is the only conclusion in terms of comparison between the two types of facilities in any of the submissions that have been provided by Encompass. Is that right?
Yes.
And you're basing that purely on the CMS codes that we heard about, that because Medicare treats them differently or under CMS they're treated differently, you're treating them as different entities or different types.
Yeah, I mean, it's a clear definition and delineation of what they are. They provide a different level of care. So speaking as an operator, one of the hospitals, actually the hospital that Ms. Chafe had highlighted in Delaware, I was a CEO of that hospital when it first opened up, and we had a great relationship with the LTAC in that community. The fact where they were significant referral source for us, which I think again indicates the difference in care between those two settings.
So then you, based on your experience with that LTAC and also with your lengthy career in this field, do you have a sense of what types of patients LTACs are treating, at least at Gaylord and HSC?
The vent population, I think, is one that jumps out to me specifically. But I know Dr. Charbonneau covered the kind of I don't want to speak to the medical side of it, but as a non-clinical person, I have a general sense of the differences of the type of patients that we get, which is indicated in the claims data, which shows the patient acuity levels between inpatient rehab and LTACs, which kind of shows in the length of stay data that we talked about before, shows a significant difference in the types of patients that we serve.
And I do want to come back to that, to the length of stay, because I think that there's an important distinction that we want to work through with you. But before we get there, do you have an understanding of the types of therapies and services that are available to patients at an LTAC?
Yes, generally.
Okay, and you agree that, well, let's put it this way. Would you agree that LTACs provide intensive hospital level rehabilitation care to patients recovering from serious illness, injury, or surgery?
Having not worked in an LTAC, again, I have a great respect for what they do and the types of patients that I'm aware of they serving. But again, it's two different. A lot of times these are patients who are lying in a bed and on a ventilator who cannot do these individual therapies that I mentioned that IRFs are known to do and proven to do through our track record.
Do you have a sense of what the percentage is of the patient population at Gaylord that fits the description you just said, which is somebody that's ventilator dependent and unable to participate in any sort of physical rehabilitation?
I do not have specific information for Gaylord, just what I've seen in the.
I do. Do you have any understanding of how much therapy a patient admitted to an LTAC can receive? does receive at Gaylord.
Specifically, no.
Surprised you that approximately 70% of Gaylord's patients receive at least 3 hours of therapy a day, and often go as high as 5 and 6 hours a day. 70%. You know that.
I did not know that specifically to Gaylord, no.
Visited either Gaylord or the hospital for special care to see what type of facilities they have?
No.
You ever asked or looked on the website to see what sort of facilities they have for rehabilitation?
I looked at the websites before here when, when the documentation was submitted from the interveners, but beyond that, no, I've not visited or requested a visit.
How large would the gym at the Encompass Branford facility be? Do you know?
I do not have that in front of me. So no, I do not have that. We can get that answer back to you all.
Would it surprise you to know that Gaylord has a 4,500 square foot state-of-the-art gym with all sorts of technical, with equipment and types of things that we saw in the bedroom of getting in and out of bed. They have a full-size car so that patients can practice getting in and out of cars. Were you aware that they had any of those types of facilities?
Saw some pictures, but no, I wouldn't say surprise is the right word, but that's good to know.
And they're actually adding 600 square feet to that gym in a renovation project. Oh, I'm sorry, 6,000 square feet to that facility to increase the space. It'll be over 10,000 square feet. Did you know that?
I did not.
Are there any types of therapy that Encompass would offer to its patients that Gaylord does not, to your knowledge?
I don't have the answer to that question. That's really speak to what we do in the inpatient rehabilitation space.
I'd like to move on to another question that you answered in response to OHS's questions in the you start out actually with the pre-file testimony, and on the slide today, you indicated that Encompass is a national leader in services, and you've got 173 patient hospitals in 39 states of Puerto Rico. That's correct, right?
As of the end of fiscal year 25, yes.
Okay, and then you've gone up 2 hospitals since the pre-file. Is that right?
Yes, 175, and we'll be adding in more later on this year as well.
So you included this information to demonstrate how successful Encompass is in penetrating the market in the United States and in Puerto Rico.
That are medically underserved for IRF services, yes.
OHS asked 3 very specific questions in the completeness filing that you responded to. It's questions numbers 8, 9, and 10. And in that, you start out with the reference to the number of states that you serve in Puerto Rico and the number of facilities that you have. But then Encompass asked, for instance, they asked in the past 5 years, they wanted you to identify any pending or adjudicated citations, violations, enforcement actions, charges, civil or criminal. That was number 8. Number 9 was any investigations, either civil or criminal, by any federal, state, or municipal agency. And 10 was any adverse private credentialing or accreditation actions which were taken against Encompass. Do you recall those 3 questions?
I'm looking at them now. Yes, I do recall those questions.
And in responding to those questions, instead of, you start out talking about all 173 facilities and all 8 regions, and then you narrow it just to the Northeast region. And you say, I'm responding to these 3 questions as it pertains just to the Northeast region. So can you tell me, as you sit here today, if you had to answer that question for all 8 regions and for all 173 facilities for the past 5 years, would that answer for each one of those questions be different?
You know, I'm the operator of the Northeast region, so I don't feel appropriate to answer for the other 7 regions. But again, I feel confident that the track record we have demonstrated in the Northeast is very similar across our portfolio of hospitals.
But you don't know. So what you did is you limited the scope of your response just to the Northeast region. But we now don't have any data on whether Encompass any facilities have violations or citations or accreditation issues in any of the other hospitals that are outside of the Northeast region. Is that right?
Again, I will just go back to my answer was geared towards the part of the company that I know the best and that I'm responsible for overseeing.
Talk to the other CEOs of the other 7 regions.
I talked to the my other regional president counterparts.
you share data among the other counterparts?
We share outcome data, our ability to get patients home, how we stack up from a net promoter or patient satisfaction perspective and those types of KPIs.
But you don't talk to them about when there's problems. You just talk about the positive stuff.
We talk locally and regionally to our home office counterparts when there are issues that arise, but with the other 7 regional presidents, it's not something that we discuss on a regular basis now.
You talked this morning about how successful Encompass has been with Medicaid Advantage authorizations. But then why are you only at 25% in the Rhode Island facility? The state of Rhode Island has a 55% Medicaid Advantage population.
Medicare Advantage, you mean?
I'm sorry, Medicare Advantage.
So listen, and again, this goes back to patients who need our level of care, and I think we pursue admissions for patients who have a rehabilitative need. So that percentage mirrors what we're seeing across the region. So much like the Medicaid population being between 6 and 7%, these are patients who have a rehabilitative need. So I think it just can't answer that question I can't answer that question a different way than saying that from a trend standpoint, where you're seeing our Medicare Advantage patient population mix increase year over year. Which again speaks to our ability to admit those patients to show through our value proposition why they deserve the care at our type of post-acute location.
I want to go back. You talked about the Danbury staffing, and that was something that we had raised about staffing shortages in the state of Connecticut and in healthcare generally. The hospital opened in September of 2025.
Yes.
You indicated that responded in the first completion response. There was a question in 22 about staffing. Do you remember responding to the question?
Not directly. I mean, if I responded to it, I responded to the moment, but I was not in this role in 2022.
Got it. Okay, so I just want to give you the data that was referenced in the first completeness response, and it indicated that you use a centralized recruiting model, and I think you talked about that this morning.
Yes.
And that you've been able to open 5 new hospitals in 2025 and maintain a 97% staffing rate without using any contract. That sound familiar?
That does sound familiar.
And does the 97% figure apply to Danbury?
Can you repeat 97%? Can you repeat what that stat?
The staffing level.
That 97% of the hospital is staffed at 90%, 97% of targeted census. Is that what I'm sorry, can you repeat that question?
Your numbers. You wanted to maintain a 97% staffing rate each of the 5 new hospitals without using contract labor. Have you been able to keep that level at the Danbury Hospital?
Yes, we are, and if you count the number of employees in orientation, as I mentioned before, we will be able at some point in Q2 to get a max census of 40 patients. So yes, we are fully staffed from a nursing standpoint, from a therapy standpoint, and from an ancillary standpoint as well when these new hires come off orientation.
When Gaylord filed its submission, at that point in time, based on Encompass's website for Danbury, there were a total of 14 positions listed. There were 14 different positions. It wasn't clear, for instance, if you're looking for a dialysis RN, it wasn't clear whether you were looking to fill 1 role or 2. Just the definition was posted. As of yesterday, there were still 8 positions that were listed on the website. Can you explain how that meshes with your comments that you're at full staff?
Yeah, I haven't looked at the website postings. We do post regularly, per diem positions to give us the flexibility if someone, were to voluntarily resign or go on vacation to, flex up and we have a census need. That being said, the numbers I cited, I spoke with our human resources director yesterday. Her name is Carrie Ford. She was the one who confirmed those numbers. So I stick to those and feel confident that is an accurate reflection of our staffing as of today.
Do you have any sense of whether the Pam Waterbury facility has done any efforts to do recruiting so that they can be staffed when they open?
Listen, we operate in markets where Pam is adjacent to us in many locations. And there was a reason we didn't oppose that project. We believe with the methodology they use that there was a deficit of earth beds in Waterbury. Is it common for some of our staff to go there or them to come us? It is, but our primary focus on meeting an unmet need. Employees are going to choose to go work where they feel valued, and we do a lot throughout our region and our company to provide that value. So, I'm not concerned at all about the impact that they're going to have on our staffing.
In terms of staffing the Branford facility, if the application is granted or approved, would you agree that you'd be competing with other inpatient rehabilitation facilities in that area, in the Branford area, including both HSC and Gaylord?
I will say we view we view LTACs more as a complement to what we do and not as a competitor. That being said, I think the fact that there was only two groups opposed to our project, none of which were the acute care hospitals, speaks to the fact that there will not be any undue harm. Again, employees have a right to choose to work where they want to work, where they feel valued. And if that happens to be with us, great. If it happens to be with the existing providers, that's great too. But I will go back to a point I made earlier. When we go into markets, we are not going to try to price anyone out. We are not going to try to recruit by offering the highest rates for nurses or therapists or EVS staff. So again, employees have a right to choose where they work, just like patients have a right to choose where they want to get care.
You did said that. You said that you make a commitment not to try to outprice other facilities in the vicinity. But Encompass do you have any flexibility in setting wages or salaries for potential new hires?
We have any flexibility? I mean, yes, as a new hospital, we will develop a wage scale as we begin posting for and recruiting for positions. So I guess you could define that as flexibility, yes.
I know you're familiar with the New York Times article that came out, and it's been addressed in these proceedings. That was posted in July of 2025. Is that correct?
Yes, I believe it was July of 25.
Were you aware that several law firms have been organizing to file or to investigate and then file a class action lawsuit against Encompass for federal securities fraud claims based on shareholder price drop? And I will clarify that in the last week, this has become public knowledge.
Where it's going.
Just want to ask if they know about it.
The only criteria is tied to.
Financial liability.
Speculative lawsuit, I don't believe it's relevant to the going criteria.
You can ask that question, but let's not.
I'm not going to. I just wanted to know if they were aware of it. I happened to see it yesterday, and I was wondering if you were aware that there are several law firms that are commencing investigations for potential securities fraud claim.
I am not aware of that. I was not made aware of that yesterday, no.
And so then I take it you haven't seen any draft complaints or anything that have been posted online.
I have not, but again, I would love to, if you allow, respond to the New York Times article.
It's okay. I have a limited amount of time, so I'd like to move on to the next witness, but I appreciate your responses. If I could, I'm done now. Do you want me to finish all my cross, or do you want to do each witness?
That would be my preference for you to. Sure.
Do all three. Okay.
What, may I inquire, when would I have redirect, Mr. Gooch?
So that would probably be. So let's get through her trial exam, and then you could do a brief practice. All of your witnesses.
Thank
you. Do it at group.
You move to Charbonneau. Saying that correctly, Charbonneau?
You are perfect.
Focus of your free testimony is on the unique and the high quality rehabilitation that patients can receive at an Encompass IRF.
Yes.
And you spoke very extensively today about the types of services and the facilities. I know that you're involved in helping design. Is that right? Yes. Much of your testimony focuses on the difference between the types of services available to an IRF versus an SNF, a skilled nursing facility, or home care. Is that a fair characterization of your testimony?
Sure.
And in fact, most of the data that we saw today, presented in Ms. Chapin's analysis in PowerPoint, it referred to the differences between IRFs, FNCs, and home care. Is that accurate?
I think it also included long-term care.
Acute, but not LTACs. It did not.
I think it also included LTAC data. I saw LTAC on here. So.
We can go, I'll go over that with Ms. Chapin, but I wanted to see if you, in your testimony, you focused principally on the distinctions between the services that are available at an SNF or home care at an FNC. Excuse me, an IRF facility, is that right?
I mean, you can characterize it that way. I think I did make a distinction between my knowledge and what Medicare considers necessary for an LTAC versus IRF versus SNF.
I think that in your response regarding LTACs, I actually put it in my outline here. You indicated that while LTACs may treat patients diagnosed with similar medical conditions as IRFs, such as stroke, traumatic brain injury, and spinal cord injuries, LTACs do not offer the same level of appropriate and intensive rehabilitation as IRFs. Paul, putting that in your testimony. Based on the questions that I asked of Mr. Gooch, were you aware of the types of therapies and services that are available at Gaylord for its patients?
I found out very recently that Gaylord participates in a PM&R residency program, so I'm not really surprised to find out that they are treating many patients similarly how we treat them in the IRF setting.
So in terms of the percentage of patients that are receiving the types of therapies that you're talking about that are exclusive in that 3-hour window at an IRF, there's 70% of Gaylord's patients are also receiving at least 3 hours per day and usually more. Were you aware of that?
Just when you said it to Mr. Gooch, but I think that accounts for the fact that they have perhaps better outcome data on getting patients home compared to other LTACs when we looked at that data nationally as well. And again, given that they are focused on teaching PM&R residents, I think that's great for the patients, and for them, I don't think it changes my opinion on what is required by Medicare for IRF versus LTAC. So the fact that they do that is actually not a requirement from CMS.
Sure, it's not a requirement, but if they're offering those services to 70% of the patients that come into Gaylord on an annual basis, then those are patients that fall on in the same kind of area as the patients that could be treated at an IRF. Wouldn't you agree?
I think that you have to look at each patient individually. And again, based on my experience with our hospitals, again, with a 12-day average length of stay, I do think that our patient populations are probably markedly different in terms of medical acuity, medical complexity, and need for probably other physician services like pulmonologists or other things that we, our patients are a little bit of a higher level, I would venture to guess. That would account for the fact that we have a much shorter length of stay in order to get patients home as well. So in my mind, I think that our patient populations are very different, even though Gaylord has a great reputation. They're obviously doing a very good job for their patients.
So you said you do know what the PM&R programs are, what a physician is that would come out of
I
it.
am a board certified physiatrist, yes.
You did not know until today or recently that the Gaylord supports a program.
I did know that they had a program, but I didn't know much about it.
It would be fair to say, we talked about the length of stay earlier. You were saying that the difference is between 12 days versus 28 at an LTAC. As a physician, you would agree that an LTAC can take a patient earlier in the recovery process out of the LTAC, out of the acute hospital setting than an IRF can. Would that be fair to say?
Yes.
So a lot of that difference in the number of days is because the LTAC is available to take someone when they're not quite medically stable, stable enough to be moved, but not medically stable. Is that fair to say?
And that would explain why, as Mr. Gooch said, we often get referrals from LTACs because they do that early part while the patients are still very, very sick and get them to a level where then perhaps they're more appropriate for IRF level care. So nationally speaking, not for Gaylord, but where we have these referral patterns, you can see that LTACs do refer patients to IRF once they get them medically stabilized. They have that benefit of that longer length of stay of 25 days to really get patients in that stable arena where then they can perhaps move to that next level of care.
And you understand, but based on what you've heard today, you understand that Gaylord keeps a lot of those patients and they actually do the therapy, extensive therapy for those patients during the course of their stay until they're ready to be discharged to home.
I think the fact that they're doing a lot of therapy is great. I'm sure that there's a significant number of patients that they work with who may still benefit from IRF level care. Whether they're actually providing IRF level care in Gaylord, I can't really speak to that.
One of the data points that frequently cited between the differences between IRF and LTAC is the discharge to community rates. And it looks like the IRF is about 60%. Or I guess actually it's 70% now. What it is, I think it's
Medicare only fee for service.
Medicare, no, exactly. And you identified that LTAC only has 17% discharge to community. Do you recall that?
Yes, again, that was Medicare, reported Medicare data.
And but you have no sense of what Gaylord's discharge rate is, do you?
I think Marty Chafin did have that actually in her slides.
So Gaylord's is closer to 50%. Is that something that you didn't know when you put up the 17%? I know you relied on national averages, but you didn't consider Gaylord's
I
discharge.
would defer to Marty Chafin. I'm not a statistical analysis person for Gaylord's.
Did you have an opportunity to read Mr. Gravelding's pre-file testimony? Do you recall, I'll make it simple for you. Do you recall seeing a Venn diagram showing
Yes.
LTACs versus IRFs?
I remember the Venn diagram.
Okay, and I can share it with you if it's easier, if I may.
Sure.
It's in the pre-file testimony. And I want to ask you about this because this is a graph that we created. It's not something that's from an official source, but I want you to take a look at that and say there is an overlap. You would agree that there's an overlap in the type of patients that are seen between an IRF and an LTAC.
So again, there are going to be patients who have the same diagnosis, but may be appropriately treated in an LTAC versus patients with the same diagnosis that are more appropriately treated in an IRF. And I think there's more than enough patients to go around based on what I'm hearing in terms of the under supply of IRF beds in Connecticut compared with other states. So I think that what will happen is once we have that availability of that resource of patients with other diagnoses that may be in that gray area, but more likely in the under the IRF area, they will be more appropriately treated in an IRF rather than a SNP.
This graphic actually doesn't even do it quite justice because the overlap is actually about 52%, all in that gray area. 52% of Gaylord's patients would overlap with patients from an IRF.
Again, you're talking just about the diagnosis category. So for example, burns, like we treat very, very few burn patients. I don't know what Gaylord's experience is, but most burn patients need to go to a burn center if the burns are severe. It's a very small number of patients. Spinal cord injury, again, a very small percentage of our patient population. In general, there are very small percentage of patients in IRFs nationally because there just are not that many stroke patients, spinal cord patients. Again, if you look at stroke in the gray area, a stroke is not a stroke is not a stroke. They're very, very different. So yes, you have it in the gray area, but what I'm trying to say is that you will have stroke patients at a level that they're much more appropriate for an IRF 12-day average length of stay because they don't have that more medical complexity that you would see in an LTAC environment. So I can't speak specifically about Gaylord's program, but my sense and what we've seen nationally is that even in states where there was no IRF previously, and they would say, well, we've managed all this time without an IRF in this state. How do you respond to that? I would say, well, I feel sorry for the patients that did not get that benefit of IRF level care for their situation, whether it's a stroke that needs IRF level care and maybe they wound up going to a SNF. So I think, again, I understand that there's always going to be a gray area and overlap if you just look at the diagnosis codes, but I believe that we will be treating patients and our overall patient population will be very different. So for example, we may take hip fracture patients, we may take cancer patients that are not appropriate for LTAC.
Understood. And I'm sorry to rush you, but I'm going to run out of time and I don't want to
Sure.
miss the opportunity. Are you familiar with severity of illness levels?
Sure.
Okay, so severity of illness levels starts at level 1 and goes to level 4 on a spectrum, correct?
I'm not really familiar with that categorization. Do you have a reference for that?
You can get that. It's in, I believe it's in Mr. Graveldig's testimony, so we can rely on that for the source. And he agrees with you that there are certain patients that are in SOI 1 that would be appropriate only for an IRF as opposed to an LTAC. And there are folks on the other end of the spectrum at level 4 that have those more complex medical needs that you were talking about. And those patients would be more appropriate for an LTAC. But in the middle are SOI levels 2 and 3. And all of those patients could qualify for either or. Some of them do come in as level 4 and they progress to a level 2 or 3, and then eventually even to a 1. There is a substantial overlap of the patient severity level in the middle, 2 and 3. Do you understand that Gaylord treats?
I understand the point. And Dr. Charbonneau, objecting to the form of the question, number one. Number two, it's already been asked and answered with respect to that middle category.
I just asking if you understood that Gaylord treats a substantial number of patients in that
So,
level 2 and 3.
so what that says to me is that Gaylord is acting like an IRF. And I am a proponent of patient choice. So maybe patients who are in that gray area where they can be treated at an IRF level or at an LTAC level should be given a choice of where they want to go.
You indicate, last question is, you indicated that you estimate approximately 38.3% of your patients to be referred to you from Yale. Is that right?
Yale?
From Yale, New Haven, yeah.
I would refer to, again, to be changed to answer.
Do you know whether Encompass has had any discussions with Yale about setting up any sort of contracts for referral?
I have no idea, no.
No, who would?
Can you repeat that question?
Sure. Your filing says that 38.3% of the patients that you plan on having at the Branford facility would be coming from Yale.
Okay.
And my question is, have you had any conversations with Yale about that?
Actually, 2 weeks ago, it's okay for me. 2 weeks ago, our Danbury CEO and Business Development Director met with leadership from Yale. The intent behind that was to see if we could provide any kind of service to them in our Danbury location to alleviate the length of stay challenge they're facing. They did note that there are some, probably not in that case because patients are not willing to drive that far. They would prefer to get care in their community. But they did note, and this is coming from my CEO, so I'm not putting words in the mouth of anyone from Yale, that they were very excited about our Branford, the potential of our Branford location. And that would be a service to them versus our Danbury location. But that is the only conversation that I'm aware of that we've had with directly with members of Yale.
Relating to the Branford facility.
As hearsay.
Understood. Noted that.
Okay, I'd like to switch quickly. Thank you very much, Dr. Charbonneau. I appreciate your responses. If I could ask Doctor, I really apologize. Okay. You made an effort today to show, I know that you disagreed with OHS's calculations of the needs-based analysis, and you showed us today what redid the numbers basically yourself using the OHS data so that you could show the bed needs. Is that pretty much what you provided today in the slides?
No, it is not at all. I did not change any number. I corrected something.
That's, I'm sorry, I stand corrected. You took the data that OHS submitted in I believe. You corrected what you thought were the errors in the calculations, but you could come up with the number at the bottom. There's still 49 beds.
Don't know the 49 beds you're referencing. I corrected what was in fact an error.
And if you correct the error, did it demonstrate that that your calculation of the number of beds that would be needed was accurate?
It's that my bed need is understated. I had a bed need of 52, and the correction to OHS Exhibit II shows a need of 59.
Now, if you made a point of saying that the methodology you utilized, in this case, you had also used in the Danbury submission, the Danbury application. And you said that it was accepted and approved by OHS at that time. I noticed one significant difference in the calculations that you ran for this particular one, and that is the addition of line 8 for the immigration factor.
That's right.
That's something new.
That's correct.
And how does that impact the calculations in terms of the math? Does it adjust upward or downward the number of beds that would be required?
It increases it. And the reason that I have an immigration here versus no immigration in Danbury is in Danbury, if you look at the geographic area, I went much broader and I went into New York. And instead of including that New York in migration, which is 10% is a typical migration factor for health planning. So I had a narrower service area definition here, and you have to consider, I'll call on the cusp of the northern of the zip code area. Those patients may go to Hartford, may come south.
But if I heard you correctly, by adding in that new line, which you did not do in the Danbury methodology, it resulted in an increase of beds for Branford. Is that correct?
Actually, I was asked and answered.
I just didn't hear the answer. I wasn't sure that's what she answered.
I'm sorry, could you answer, please?
Sure, mathematically, that is correct. If you have a migration of 10% or no in-migration, then an in-migration factor will mathematically be a bigger number. The need for the facility does not turn on a 10% in-migration. I feel it is appropriate in this instance.
You had a bed needs slide number 5, that shows that hospital-based inpatient rehab bed occupancies in the hospital setting is up to 90%, and that helps you to reach the conclusion that additional beds would be inpatient rehabilitation beds would be a good thing for Connecticut. Do you remember that slide number 5?
I have it in front of me, yes.
And that, if I look at the data, that's you're referring to from 2024, is that right? Yeah, occupancy rates.
That's correct.
Okay, so that does not take into consideration, you haven't looked at it since either the Danbury facility opened, or we obviously can't look at the data relating to the Waterbury facility, but that data predates the opening of these other 2 facilities, is that right?
That's correct, because they were not open at that time. Danbury is exceeding its projection, and I would expect it not to materially impact this unless it would increase the overall.
Thank you. And on slide number 6, in post-acute care, this is what I was referring to with Charbonneau. In this, you do not include on this list of post-acute care services, you don't include LTACs, do you?
Do not.
And so when you indicate that there's a gap in service, the gap in service is premised on the understanding that Gaylord does not provide the types of services that an IRF would. They're not included even on here, are they?
Well, this would not be specific to Gaylord. This would be specific to the state of Connecticut, and how the state of Connecticut's IRF or home health or skilled nursing, or you're asking for LTAC. I did not show LTAC because it is not typically a substitute for IRF, since they are CMS distinctly different services. So I just did, it wasn't an oversight to Gaylord or a slight. I was looking at the post-acute care services that oftentimes can be substituted for IRF.
We're talking about a catchment area though, or a service area that already has two LTAC facilities in it that have the ability to treat a substantial percentage of the patients that could go to IRF. And none of the, I know you're saying it's to Connecticut in general, but the particular service area includes two LTAC hospitals that provide overlapping services. So my question is don't you think it's important to understand the services that these two facilities provide and factor that in determining whether there really is a need?
I could put that on slide 6. I absolutely can. It would not change the bed need calculation regardless of what utilization Connecticut has in IRF versus the nation. That would not change the bed need calculation of IRF, which is very different than LTAC.
In your recalculation of the numbers that you did of the OHS numbers, actually, I'm sorry. You looked at the submission from Gaylord and you redid the needs analysis that Gaylord submitted. And you indicated that you modified it to include the rate of discharge at 4.2 for a Medicaid Advantage. Is that right? I'm sorry, Medicaid. I keep saying Medicare Advantage.
I did not redo the Gaylord calculation. I corrected an error in the math and then I updated it with 2031 population. So I just want to be very clear for the hearing officer in the record.
Okay. In your calculation, you did not account for the 4.2 out of 1,000 beneficiaries for Medicaid, Medicare Advantage, did you?
You're asking me on the Gaylord?
No, on your own submission, on your analysis.
I would say that I accounted for Medicare Advantage patients served, but I did not divide the patient population by Medicare Advantage versus traditional Medicare versus everyone else, which the Gaylord approach does. You have 3 buckets. Right. I had 2 buckets.
Okay. But the one of the buckets that's missing has a 4.2% utilization rate, which would severely decrease the number of beds that resulted from the calculation if it had included that number.
Not agree with that characterization. Number one, it's 4.2 discharges per 1,000 beneficiaries, not a percentage. And number 2, there is still a bed need minimum 40 beds for Gaylord's calculations, and that's using a national average for the Medicare Advantage, not a percentile higher. It's also using a national average for the traditional Medicare. There's still a bed need. There's still a sufficient bed need. There's still a gap in care.
So a quick question about one of your slides shows the cost. I believe it was Exhibit G. And you would agree that even on your own analysis that the daily rate for an LTAC is actually lower than, is that right?
Can you point me to what slide?
Exhibit G. I don't know. It was Exhibit G that was in your pre-file. It was listed that had the cost for an acute care, for an LTAC, for an IRF, and down the line.
Yeah, it's actually in the presentation today, slide 21. On a per day basis, that is correct. The reimbursement is per case. And so the per case payment is around 51,000 for LTAC versus 27,000 for rehab. To your point, the per day, if we break it down, is less per long term, which points to the difference. The 28-day length of stay nationally for an LTAC, it's 12.5 per IRF. It's apples and oranges. My point here was to talk about the difference as recognized by CMS.
I have 1 minute just to check my points. This is my cross. Thank you very much.
We note that the first selectman doesn't appear to be on, that was the individual you. Oh, sorry. Wonderful.
Now, fine, I have till 12:30. So if there's something else I have, can wait a little bit, but I can go now as well.
No, we're going to take a lunch break in a few minutes. So if we can have you before the lunch break.
That's fine. That's great. That's fine. I just wanted to take a moment of everybody's time to say that so that you're aware that the town of Branford not only fully supports the Encompass facility, but excited about the opportunity. I look at it from more of a practical standpoint, and I apologize because I don't have some of the science behind all of it. I look at it as an opportunity for services to my constituents in the surrounding communities and giving them the opportunity to get services close to home and close to where they live. And from that aspect, I think it's a great opportunity for us, the communities to the east of us, some close to the west of us, and it gives great chance for not only the patients, but the families of those patients in our area to be close and feel like they're at home. I think of a story that happened with my neighbor a year and a half ago, and she had a health incident. She was 91 years old, and she didn't want to go to New Haven. She just didn't want to go to just at that far. And when she eventually ended up in New Haven, because I made her, she was 91 and wasn't optional. Then when there was talk of where she would go next, she didn't want to go to Wallingford. She didn't want to be that far. She didn't want to go. She wanted to be home or as close to home as possible. And I think this gives those people that I'm here to represent an opportunity for that. Science behind it, math, I'm not as versed at, but for us as a community, I think this is a great opportunity. So I just wanted to take a minute of your time to say that. I don't know. You could know what we do now. We have lunch, I guess.
And just for the record, this is for Selectman Brooks, right?
I'm sorry. I'm First Selectman Josh Brooks. Yes.
Was wanted the transcript to reflect.
Of Branford.
So thank you for making the trip up. We appreciate that. The plan is to take lunch now until 1 o'clock back. You prefer to do redirect or, redirect? My brain is
Yeah, I think
shorting a little bit.
to redirect to the cross.
Yes. Okay. And then we'll move on to your cross and you can correct. Well, just a reminder to anyone who is in the room or participating remotely, if you haven't signed up and you do wish to make public comment will be 1 o'clock. And again, these microphones in the room will stop anything you say. So we will stop the recording now, but be cognizant of that fact. And I think that's a good place to stop. So thank you very much.